I think we should give ourselves a round of applause. I'm just so excited that we're all here. This is fantastic. Chantal was reminding me yesterday that it was a year ago we submitted the grant, October 15th to CCS. And here we are now, a year later, and so much progress has been made and we're just getting started. So welcome everybody. It's so nice to see everyone in 3D instead of Zoom meetings for once. I'm going to begin with our land acknowledgement. So as we gather here at the Arthur J.E. Child Comprehensive Cancer Center for the CAN-PACT National Network meeting, we pause to honor and acknowledge that we're on Treaty 7 territory, the unceded ancestral lands of the Blackfoot Confederacy, comprised of the Siksika, Piikani, and Kainai First Nations, the Tsuut'ina First Nation, and the Stoney Nakoda. This includes the Chiniki, Bearspaw, and Goodstoney First Nations. The city of Calgary is also home to the Métis Nation of Alberta Districts 5 and 6. We recognize the enduring relationships that exist between Indigenous peoples in this land and the profound cultural, spiritual, and historical significance it holds. We are grateful for the teachings, stewardship, and resilience of elders, knowledge keepers, and all First Nations, Métis, Inuit, and urban Indigenous peoples, whose communities continue to thrive, heal, and uphold traditions here. In our work as cancer care practitioners, researchers, and partners, we acknowledge our responsibility to listen, learn, and collaborate with Indigenous patients and communities to improve health outcomes and promote respect, equity, and inclusivity. This land acknowledgement is made in the spirit of respect, reconciliation, and gratitude, with a commitment to fostering meaningful relationships and collective well-being for all who call this place home. And specifically within CAN-PACT, we also acknowledge and respect that many psychedelic substances have been used as plant medicines by Indigenous peoples worldwide within cultural and ceremonial contexts for centuries. And Ron will be telling us more about that later today. And they continue to be sacred medicines for these communities. So I'm just going to begin with a short moment of reflection and meditation. So if you care to, just check your posture, notice if you're slumping a little bit and perhaps placing your feet flat on the floor, sitting in a way that supports the easy flow of breath in and out of the body. And if you care to, allow your eyes to gently close or soften your gaze, perhaps connecting with the image of the mountain or the heart on the screen. As you breathe in, feel the breath filling the body, and as you exhale, sinking down into your seat, releasing tension, perhaps in the face, the neck, shoulders, the chest and belly, through the legs and thighs and buttocks, and feel the feet connecting with the ground. Allowing the breath to come and go, feeling the rising and falling in the body, the passing of each breath. So noticing where your thoughts may be, the airport, the hotel, your to-do list, your inbox, and as you exhale, bring those thoughts into the body, resting on the breath. Making a commitment to leave all those other thoughts of past and future on the shelf for now. And as we transition to this time together, considering perhaps your own personal intention in being here, what motivates you to do this work? What speaks to you deeply in whatever part of the work you're involved? As a clinician, trainee, a researcher, someone with lived experience of cancer. So consider your personal intention over these next day or two that you join us. How you want to arrive and connect in this space as we build this community together. And acknowledging also a collective intention to be heartfelt, to listen, to contribute, and to learn. As we build this project together, with everyone's contributions equally valued. So just a few moments more to rest in the breath. Allow our intentions, both personal and collective, to settle. And with your next exhalation, just gently opening your eyes and returning to space. Welcome, everybody. Looks like you're much more present now. And let's move on with the program. We've got a lot of exciting talks and interaction ahead of us today and tomorrow. I'm just going to begin. Our theme for today is really the past and future of psychedelic-assisted cancer therapy, and how we got to be where we are today. So I'm going to give you a bit of a background on our project in particular and this area of research generally, talk a little bit about the rationale for creating CAN-PACT. I won't need to talk too much about the cancer experience to this group, but reviewing some of the current psychosocial treatments for the problems we're here to address. What are the opportunities and the gaps perhaps there? A little bit about psychedelic-assisted therapy generally in cancer, what we already know, and then just review the objectives of the network. And there's 6 of them. Well, I've collapsed 4 and 5 together into clinical trials. And then we're going to call everyone to come on down, and we're going to meet the team and begin to get to know each other on a deeper personal level. All right, so why are we even here? Well, we know that there's a lot of difficulties, psychosocial issues, living with cancer. And our focus in the grant has been on people with more advanced or what we might call incurable forms of cancer. We know that existential distress and demoralization are quite common and difficult to live with. So we've honed in a little bit on demoralization syndrome, which is defined as an existential syndrome characterized by loss of meaning, dysphoria, disheartenment, helplessness, and a sense of failure. This type of experience for people can be difficult to live with. It's hard for people to see, for healthcare providers, for family members and loved ones. And while there are some options for managing demoralization and related issues and concerns, still I think we can do better. So for example, antidepressants are sometimes used, but medications really don't touch this kind of existential sort of suffering. We do know that psychotherapy can be effective, but it doesn't work for everybody. There's limited access, and the effect may take some time. So research over especially the last 15 years or so, but also going back quite a bit, these therapies using psychedelics, and a lot of the work has been with psilocybin, show strong promise for this group of people. So I'll review a few small clinical trials in the United States, but we definitely need more definitive trials and more research to answer so many unanswered questions. There's also no infrastructure for this work in Canada, like nothing really at all. So we identified a need to create networks to move this forward and to include policymakers and stakeholders from all the different groups that really need to be involved if we're going to move this forward. Okay, so a little bit more about the common cancer experience. So these existential concerns I talked about, anyone when they're diagnosed with cancer, no matter how good the prognosis, has that existential threat. Right? Oh, I always knew I was going to die. We can't pretend we're not going to, but maybe this is closer in the future than I thought. And maybe I need to actually start thinking about what this means. So in our culture, there tends to be a fear or aversion to talking about death or dying, to thinking about death or dying, and that's often brought off with the cancer diagnosis. Many people experience this loss of meaning and purpose. A central feature is loss of control, right? So we deludedly go through life thinking we have some control over what happens to us. A diagnosis of cancer makes that very clear to people that that's actually not the case. And so how do we live with this uncertainty, this loss of control, loss of predictability and routine in our lives and our futures? There can be a sense of isolation, sort of existential isolation, even with as much social and family support as you may have. Still, people talk about feeling very fundamentally and profoundly alone and disconnected in the experience. There's a whole range of emotions: grief, fear, anger, depression, shame, guilt, really runs the gamut of it. And there's a pretty predictable sort of pattern of the different types of emotions people will experience. And then depending on the treatment and the type of cancer, there's all kinds of physical symptoms: pain, fatigue, sleeplessness. And then after a person is treated, or even at the beginning, there's always sort of waiting for the other shoe to drop, right? So this fear of progression or recurrence, scanxiety every time people have to go in for a follow-up. So digging into the existential concerns a little bit more deeply, I talked about demoralization syndrome, so loss of meaning, dysphoria, disheartenment, helplessness, a sense of failure. These concepts are all tied together with spiritual distress. So loss of meaning, loss of purpose or connection, feeling isolated, losing that feeling of being connected to the moment, to self, to others, to nature, to something sacred, to something larger than oneself. So this idea of spirituality. And we do find that when we assess these things in people with cancer, about a quarter of people, especially with the more advanced cancers, are suffering from significant levels of these problems. And I talked about fear of death and dying. And sometimes that loss of control and fear of death, of dying, might motivate people to think about medical assistance in dying. And we like to think that, well, there's probably lots of other options within palliative and psychosocial care before people need to turn to that. Okay, so let's talk about current treatments for demoralization syndrome and a lot of these different sort of cluster of symptoms that we experience. So there are psychotherapies out there that are really good. And I find a lot of times in this space, people make the argument that there's nothing there to treat these problems, and so we need psychedelics. I disagree with that, actually. There are a number of fairly well-validated multi-session psychotherapeutic approaches to dealing with these, like meaning-centered psychotherapy. Bill Breitbart and his team at Memorial Sloan Kettering have developed that, tested it out in a few clinical trials, and it can certainly help. Calm therapy, so that's managing cancer and living meaningfully, developed by Gary Roden and his colleagues at the Princess Margaret. Who's from the Princess Margaret here? We got? Are there any Princess Margaret people? There we've got one. I know we have a number in our network. I wasn't sure if people were going to make it. And that calm therapy has been rolled out around the world and can also be helpful. Dignity therapy, that's Harvey Chachanov from Winnipeg. He's also part of the network, but I don't think here. So that's really around trying to restore a sense of dignity, usually at end of life, through sort of storytelling, narrative review, life planning, sort of planning for the end of life and things people might leave behind as their legacy. And then mindfulness-based cancer recovery. So that's our program that we developed here. And that's training in mindfulness meditation with some mindful movement and various attitudes around mindfulness that we know through many, many clinical trials can help people cope with a lot of the symptoms that I listed, as well as the existential stuff. So these therapies exist. So why do we need something different? Well, I think there's a possibility that combining these with something like a psilocybin dose, a high dose of psilocybin that induces a mystical experience, might actually help to springboard some of the work that's being done in these types of therapies. So it might be synergistic. It might make a quicker kind of response in people who are really sort of short on time or feeling, that time is limited. And it might also make a larger response for people. It might last longer. We might be able to be more efficient in how we deliver these treatments. So that's kind of the basis of how we rationalize CAN-PACT. So a couple of the seminal clinical trials that have already been done in the area, and I know people in the network are very familiar with this, but we've got a wide range of people here today, so we kind of want to get everybody up to the same speed. So a clinical trial in 2016 came out of New York University, Ross et al. It was only 31 people, so a very small study, and you'll see that with the other study as well. But they were randomized into a crossover design, so everybody got either a high dose of psilocybin or a low dose of a placebo substance, which was niacin. And they all had, so when we talk about the therapeutic part, and this is a plug for clinical trials tomorrow, you can come and we'll talk about that a lot. There is understanding there needs to be some kind of integration or preparation sessions to prepare a person for a dosing session, and then some form of integration. So it's been done in a kind of non-directive, supportive sort of way, which is what they did in this trial. But what they saw was rapid and sustained improvements in outcomes like depression, demoralization, hopelessness. And these were very large in some people, and reductions in suicidal ideation, and followed up for up to 4.5 years, people seeing these benefits. So it was a really large effect in that trial, and around the same times, the Johns Hopkins group, led by Roland Griffiths, did a very similarly designed but slightly larger clinical trial, and really found the same kind of thing. They gave many, many different outcome measures and followed people up. So we saw decreases in depressed mood and anxiety, increases in quality of life, meaning in life, optimism, decreases in death anxiety. And in this group, actually, they've been followed up longer than 6 months too, and seen sustained improvement across many people. So this kind of research has really picked up. I'm sure many of you are aware in lots of different areas, in this area as well. So just a couple of years ago, there were 2 open label pilot studies that came out for depression specifically in people with advanced cancer. And in these trials, they offer group preparation and integration sessions. And it was open label, so everybody got the high dose therapy. And so these studies showed that it was possible to do this kind of intervention in a group setting, and also showed some improvements. And we're going to hear from Dr. Back from Washington a little bit later today about the work they've done in this space as well. So another bit of background is the regulatory context. So currently, psychedelics are classified as Schedule III substances under the Controlled Drugs and Substances Act in Canada, making it illegal to possess, produce, or distribute, but ironically not illegal to use. I don't know, maybe Ron or Dave can explain that a little bit more. And if you want to do research in this area, you have to submit an application for each clinical trial to Health Canada, like a regular grant proposal, to get permission to use the substance. Now, for clinical use in 2020, Health Canada allowed physicians, caregivers, and patients to request case-by-case access to psilocybin for palliative care and end-of-life distress, which is kind of ill-defined through the Special Access Program. Now, the issue here is that people have to apply case by case. It can take a long time. Just talking to Jade about her experience where, by the time the paperwork's in and approvals might come, it's too late for the patients to get access. So that program is not very effective. So that leads us to the objectives of CAN-PACT. Our first objective is to build capacity to do this kind of work. And so we created a network and did an environmental scan, and that's why you're all here today. The second is to set research priorities. So don't assume that we know the answers, is to determine key research priorities in advanced cancer, although we may be broader than that, through stakeholder engagement. So I'll tell you more about that. Education and training is a huge piece of it. Yeah, Ron's laughing because that's his portfolio. So we need to develop and implement training and education programs for a lot of different groups of people if we're going to do this work. We have to train clinicians. If we're going to deliver the interventions, we need to train clinicians to refer people, the researchers, the patient partners, the policymakers, all the trainees as well, the public. We basically have to educate everybody. And then the clinical trials. So we're going to start with a pilot study, collect pilot and feasibility data, probably offering whatever version of the psychedelic-assisted cancer therapy we decide on to people in 2 sites of our multi-site sort of network. And then once we've done that and ironed out some of the feasibility issues and how we want to design it, we're going to do a multi-site clinical trial. And we started at step 5 with the multi-site clinical trial. Where's Harriet? We were just talking about this. We actually started 3 years ago by developing a multi-site clinical trial because there was a call from CIHR for research in that area. So through the Canadian Cancer Trials Group, and Harriet will be telling us more about how that works tomorrow, we came up with a trial and we got 5 sites together and we submitted it to CIHR, and of course it didn't get funded. And that was in 2022. And so we did it again in 2023 to CIHR, didn't get funded. So in 2024, I said, that's it. Well, Harriet made me. We're expanding our reach. So we applied to 4 different opportunities in 2024. And the one that got funded was the Canadian Cancer Society Breakthrough Team Grant. So that allowed us with partial funding from CIHR. Yeah, we did get some CIHR funding. Actually, we got a couple of packets of CIHR funding too. And so that allowed us to go back and do steps 1 through 4, which we weren't even going to do. We were just going to go right to step 5. And so now we're going to have to reconsider step 5 in the context of the first 4 steps. But the Breakthrough Teen Grant is amazing because it's allowing us to do this in a really systematic way that I think is going to have lasting effects. And then there's the policy issue. So thank goodness we've got Dave Clements, who's here somewhere. There he is, who has a background in policy and knows much more about this than us clinical researchers. And so we're going to try and influence the Canadian healthcare policy to support integration of psychedelic-assisted cancer therapy should it prove beneficial in our clinical trials. So it's a lot. We've got a lot to do and 5 years to do it, although I'm sure it'll take longer than that. But we're well on our way. So objective 1, build the network. So we did an environmental scan. We already had our network from CCTG of the 5 different sites. So we took suggestions, we searched around, we looked at the research, we looked at the ongoing trials. Harriet, Ron, and I are kind of the co-leads here. So we went through all the lists, we invited network members. We tried to sort of get representation across all the groups we want. And so we're still in the process of doing that and building the network. And we're also haven't even started yet, but we're going to build an international advisory board. So we're collecting names for that. And certainly open to suggestions of people you think should be on that international advisory board. And give your names to Chris. Where's Chris? Oh, he's out in the halls. And Chantal. Yeah. Okay, we're going to introduce everybody in a minute. I don't know, maybe we should know that first. So our network consists of academics and researchers from psychosocial oncology, from psychology more broadly, from palliative care, and also people from sort of psychiatry, medicine, health sciences, and nursing. So we've already got people from all those different fields. We've got clinicians. The model we're using in publicly funded healthcare systems is within psychosocial oncology and palliative care. So at each of our participating sites, we have got leads from psychosocial, the ones who give permission for their clinicians to do stuff. And then we've got psychosocial oncology clinicians from each of our sites. And there's a few gaps in some of these places. We've got palliative care leads at each of our sites and palliative care clinicians. So that's how we're going to deliver the therapies at these different publicly funded cancer centers. Where we've got policy folks from provincial agencies, from Health Canada, national representatives, and we're hoping to get more Indigenous and other people in the policy space. I don't know why policy doesn't seem to be as sexy as the other groups, but if you have an interest in policy, join our policy committee. And of course, we have patient partners. And we'll hear about more about that in our priority setting. So here we're trying to get people across provinces with diverse demographic backgrounds, diverse experience with psychedelics, different types of cancers, all that kind of thing. Okay, that was objective 1. So we've made good progress there. Objective 2, this is our stakeholder priority setting that is also underway. So we've already actually done surveys and interviews with over 700 patients, healthcare providers, and policymakers. And that's Haley Schumann. She's going to tell us about that work tomorrow. It was her master's project. And now we're starting a James Lind Alliance priority setting partnership, which is this. So it's an established process through this group, the James Lind Alliance out of the UK. They give us a facilitator to help us do it. We follow the steps that they provide. And so we established the partnership. We formed a steering group with some people from this network, but also some people from outside this network that fit sort of key demographics and stakeholder groups. And so we're going to go through this. They call it uncertainty gathering. Really, it means is just collecting questions. So uncertainties are just questions. So we're going to determine the scope. We're going to build a survey, a series of surveys actually, and ask just people, what are your questions about psychedelics for people with cancer? And so we'll distill them down. We'll take out things that have already been answered or are unanswerable. And through a series of rounds here where we go through data processing, prioritization, there's a final priority setting workshop that will probably be happening around this time next year when we have our network meeting. Where we bring in other people, not us necessarily. It's mostly clinicians and patients to get their perspectives. And then we come up with what's called a top 10 list. So they distill down all the questions into top 10 unanswered research questions in this space. And that, we hope, will be a guiding framework going forward, not just for our group, but for many years to come for research and policy in this space. So that is underway. We've formed the steering committee. It's about we're trying to do it in a year. Well, we're already 3 months into it. So by this time next year, we'll be doing the finalizing that. Okay, objective 3, training and education. This is a big one. And so Ron and Leah Mayo, where did I see Leah? There you are. We're so happy to have Leah with so much experience, is co-chairing training and education with Ron Shore. And so where we are now, lack of specific training for people or access to training. So we need to develop curriculum for training clinicians, for training researchers, for patient education in the public, also for how do we need to talk to policymakers, what kind of information do they want and need. And so at the end, we'll have widespread implementation of the education, but also the clinical components and that kind of thing. So I guess I can make a plug. Tomorrow, we're going to be doing breakouts based on subcommittees. So there'll be one for training and education that you can go to, learn more, and maybe join the committee, or if you're already in the committee, you'll be invited to that. So objective 4 and 5 are around the clinical trials. So Harriet and I are leading that subcommittee. We've done a lot of work already on designing our pilot trial, and our main objectives are to see feasibility of doing this therapy with groups and with a hybrid in-person online sort of format. So is that going to be feasible? And we're addressing individually the impact of the psilocybin-assisted therapy with low and high dose. And we're combining that to isolate the impact of mindfulness or supportive therapy, also having lower high dose psychotherapy. So as I said, we're going to planning group administration with this hybrid online in person. And so the way we are planning to do it is to have these 4 different groups. So some people will get the high dose and the full-on intensive preparation and integration. Some people will get the high dose, but a very minimal preparation and integration. Some people will get the low dose, but will get the more intensive mindfulness training. And then a 4th group will get the low dose and minimal preparation. So the folks who don't get the high dose will then afterwards get an open label high dose. So if you want to talk more about that, we're going to go into the weeds tomorrow in the clinical trials working group. So the multi-site clinical trial, as I mentioned, that's where we started, but we've taken a step back now. We still plan to partner with the Canadian Cancer Trials Group Supportive Care Committee. We're going to optimize the intervention through the pilot work, and then we're going to test whatever we land on. We don't know what that's going to be, right? Maybe we don't need all this intensive, sort of preparation and integration in this group of people. So whatever it turns out to be, we're going to test that optimized intervention across Canada in a multi-site trial. We'll likely compare the high dose with a low dose as well, but really it's all up for grabs. And so generally we're following pragmatic design principles to try and do this in a naturalistic setting in publicly funded cancer centers with staff, the palliative care and psychosocial staff that's already in place there. And so that would lead to it being much more easily implemented if it proves helpful. Okay, objective 6, policy. So how are we going to improve policy? Well, Dave's going to help us figure that out. We might do things like develop policy briefs, conduct workshops. And we definitely are trying to integrate policymakers. It's been interesting because the few we've asked, say, from Health Canada, they go to get permission and they're told they can't because it's a conflict of interest. So we're maybe targeting people who have retired from those spaces, who still have a lot of knowledge. So we're working on that if people have ideas. We want to collaborate with the regulators as well, and at some point find out what kind of information these people really need for the kinds of decisions they need to make. And there's lots of different places that policymakers and regulators come from. So there's the sort of National Health Canada, but there's also provincial professional regulatory bodies, for physicians and psychologists and that kind of thing. There's the provincial cancer agencies. We're trying to get a drug policy lawyer we've invited to join us. And we haven't had much luck with, politicians or provincial ministries of health, but we're still working on all of that. Okay, so let's bring it all together. So here's our behemoth as it continues to grow. So we've got a steering committee at the top, and that's really the original investigators from the CCTG work who meet together and kind of steer the whole thing. We're going to have an international advisory council or board to advise the steering committee. And then we've got the executive committee. So that's the PIs on the grant. So that's me and Harriet and Ron and Chris, our program manager. And then when we go down into the committees, we've got the administrative team, who I'll introduce in a little while, doing just operations, communications, planning these meetings. Education, you can see it's really big. It's already got 3 subcommittees, so professional training, patient and public education, trainee, community network, work for the research trainees and all that. And then clinical trials. So as I said, Harriet and I are leading that. So we've got to deal with the Health Canada application. We've got to deal with all kinds of stuff with the provider, design the pilot study, figure out how we're going to do that, and the multi-site trial eventually. And the policy people have to deal with regulatory issues and work on knowledge translation and mobilization there. And then we've got a committee for the priority setting partnership that I mentioned. And so that's actually a master's project for another student, Nisha. Is she here? There she is. So that's Nisha's master's project. And we've got Chris and patient partner Hillary. Where's Hillary? There she is, who's co-leading that as well. Okay. So that is the really short version of the history and the objectives. And now we're going to meet the team. Okay, so I am going to ask everybody from BC who's here. So this is everybody from BC who's in the network. Not everybody is here. Alan Bates is the lead for BC. And I am going to ask you all, come on down. So come on down. I'm going to turn on this mic. Okay, hold on a second. Mic 1. There we go. And Alan is going to introduce the folks from BC that are here.
Excellent. Hey, everybody. Yeah, I'm Alan Bates. I'm the Program Medical Director for Supportive Care at BC Cancer and a clinical professor of psychiatry at UBC. So we've got an awesome team from BC, and for the folks that are here. So Dr. Zach Walsh, I'd say we went way back, but we actually just met as we walked up here. But very impressive individual. He's a professor in UBC Psychology, has a background in research in cannabis, hallucinogens, substance use, harm reduction, drug policy, and mindfulness, and several other things. And his work's been supported by CIHR, SHIRC, and Health Canada, and other organizations over time. So amazing to have Dr.
Hi, Zach.
And next to him is Dr. or John Jose Nunez. So John Jose and I have been working together for a number of years now. He's another psychiatrist at BC Cancer Vancouver. He's the Associate Medical Director for Supportive Care. He's an Assistant Professor in the Department of Psychiatry at UBC. And he's a very unusual psychiatrist who knows as much about computer science as he does about psychiatry. So he's been working on AI models for the past 8 years or so. And so if you want, if we do anything to do with natural language processing and that kind of thing,
yeah,
JJ is our guy. And the next to him, we have Hillary Horlock. So I have the pleasure of meeting Hillary at CCTG conference and also through this work. So she's one of our patient partners. But I've noticed she's one of the patient partners who knows more about stuff than I do a lot of the time when we're talking about health. And that's because she's a senior enterprise architect specializing in healthcare technology design. And has been involved in many different things to do with healthcare. And then last but not least, Dr. Michael McKenzie. So Michael is co-chair of the CCTG Supportive Care Committee. He's got extensive experience in clinical trials. He's a clinical professor in radiation oncology within the Department of Surgery at UBC and within the Provincial Health Services Authority. So he's also the lead for medical assistance in dying and advanced care planning. And also the medical director for quality at BC Cancer. So there's other folks, sorry, I'm standing in front of everybody. There's other great folks at BC, they're part of it too, but that's everybody here. Happy for, if I messed anything up or anybody wants to say more about themselves, happy.
Awesome, thank you. No, that's great. Thank you, Alan. Okay. All right, Alberta Part A, come on down. If your name's on this list, come on down. I was not nearly as organized as, I guess I don't need both of these, hey? I'll just use this one. I am not nearly as organized as Alan, and I don't have a nice bio written for everybody. But if you're on this list, okay, let's go over here. So we're not in front of the screen. Come on over here. Come on down, come on down. See, I don't really even know how to introduce her. All right, so this is part A of Alberta. We actually get 2 screens. I'll move on to this side. So super happy, and I'm sorry, as I said, I wasn't organized enough to get the full bio for everybody, but come and talk to them. So Marnie Armstrong is our, I guess, liaison between Alberta Health Services Supportive Care and University of Calgary Supportive Care, and so she runs a sort of implementation pipeline about how to, well, why don't you, hold on. That's great. You just introduce yourself.
Great. So hi everybody. I'm Marnie Armstrong. My role is I'm the scientific lead for supportive care services and patient experience here for the province, actually, but located here out of the Arthur Child. But as Linda mentioned, part of my role is really trying to help bridge and support a research to practice pipeline, but across all of supportive care. But I will say clearly my background is not cancer. I'm in this role for 8-9 months now, but I spend time in diabetes, cardiovascular, and kidney health. So I'm new to cancer, but not new to sort of research within the health system and trying to support it that way.
Awesome. Thank you. And I guess as you're trying to piece people together in our little map too, right? So Marnie would be sort of the psychosocial administrative lead for Calgary in that role. I'm going to let you guys do it. You'll do a better job.
Hi, I'm Nikki Kane. I am the program manager of the Research and Evaluation Unit at the College of Physicians and Surgeons of Alberta. My background is in nursing and in public health, and I'm coming to this group, I guess, kind of with a regulatory and policy lens, and how we can see physicians prescribe psilocybin safely for cancer patients.
Sweet, thank you. Thanks, Nikki.
I'm Jade Hart. I work frontline palliative care. I'm a social worker, and so I'm doing the work with patients when they want it, if we can get approval.
And Jade already has training.
Yeah.
In psychedelic-assisted therapy. Yeah.
Hi, I'm Lyle Galloway. I'm one of the palliative care physicians here. I lead the pain and symptom management palliative consult team in this building. And I don't know, you can say what role you've got in mind for me. I think I'm listed as a clinician. I have done training in psychedelic-assisted therapy and research as well.
Yeah, and Lyle probably has as much hands-on experience in this work as anyone in Canada.
I'm Sasha Malia. I'm a clinical psychologist in the Department of Psychosocial Oncology here. I am lucky to be co-facilitating the mindfulness-based cancer recovery program with Linda and hoping to get trained up to administer PACT.
Hey, I'm Leah Mayo. I'm the Parker Psychedelic Research Chair here at Calgary. So I do psychedelic clinical trials, mainly in the mental health space. But I'm excited to play whatever role I can in supporting the growth of this space here in Calgary and across Canada, and very excited to work with Ron on the Training and Education Committee. So come to our breakout session, not that it's a popularity contest, but it'll be good.
No, you have to come to clinical trials. Come on now. All right, that worked really well. Thanks, you guys. So give them a round of applause. Thank you. All right, Alberta Part B, come on down. Alberta gets 2 slides and so does Ontario. Do you want to say a couple of words?
I can just introduce myself.
Yeah, go ahead.
My name is Purdy McKenzie, and I have participated in PAT, which was very significant, and I'm very excited to be part of this this council.
And we're so happy that you're here, Purdy. I first met Purdy over 2 years ago when she told me her story of doing psilocybin-assisted therapy a couple of times. And she came and presented at the Society for Integrative Oncology conference we hosted here in Banff in 2023 and shared her story. So yeah, I know 2 years ago. So I'm so happy that you're here.
Yeah, me too.
Yeah. Okay, I'll do Julie. So Julie DeLeemans has a doctorate in medical sciences. Julie has so many different roles in this project. She's currently a postdoctoral fellow with me and is also a cancer survivor, almost 20 years, 20-year cancer survivor. So was diagnosed as a young adult with stage 4 laryngeal cancer and had surgery at that time or removed her voice box, which is why I'm speaking for her here. But when you get up closer, you'll be able to have a conversation one-on-one with Julie. And so she's also going to be leading an exercise tomorrow that I'm not supposed to call a Deaf Cafe, but that's kind of what it is. Yeah, so that's an optional experience for people who don't want to go to any of the committees tomorrow. Anything else I should? She's also a death doula. Yeah, and she does biofield therapy. I mean, Julie does so many things. Yeah, so come talk to Julie after. Okay.
Hi, everybody. I'm Jamie Peterson. I'm a PhD student working under Dr. Carlson. I'm leading my own projects on nature therapy, but I'm also supporting this CAN-PACT research as well. So,
hi, everyone. I'm Haley. So we're all part of the Linda Carlson gang. I've been working with Linda for about 3 or 4 years. I just finished my master's with her, and I'll be speaking about that tomorrow. And I just started medical school in a combined master's and MD program.
Hi, everybody. I am Adele. I don't know if you've probably seen my name once in a while pop up. I do the communications for CAN-PACT and communications for everything else for Linda. So, yeah.
Well, if Adele's following you around with a camera, just smile and wave.
Yeah, just smile and wave. That's it. That's all we need. There you go.
Hi, everyone. I'm Chantal Savard. I am Linda Carlson's research assistant. You definitely have seen me in emails. I was actually just talking about to her yesterday about it, how this time last year, we were just in the grant writing part of CAN-PACT. And so it's been such a wonderful year. So thank you all for coming. It's been such a pleasure to have you here and to see you all in person. And so I will be supporting you all wherever, whenever. And yeah, so if you ever need anything, you can always reach me or Chris.
hi, everyone. My name is Nisha. I'm a first-year clinical psychology graduate student in Linda's lab. So I'm quite new to the lab, and I'm very excited to be working on research in this area, and I'll be working on the priority setting partnership that Linda was speaking about before.
Why is my heart racing? This is scary. Hi, I'm Hannah. I'm a PhD student in clinical psych in Linda's lab. I completed my master's last year with her as well. My research has been mostly in mindfulness, and specifically we're working on the Seamless trial, which is a mindfulness app for cancer survivors. But this is just super interesting, just like clinically for my training. This is such a wonderful opportunity to be able to be here and learn all about this CAN-PACT stuff. So yes, I'll just be around taking photos and notes and soaking it all up.
Thank you. Good afternoon, everyone. I'm Chris. I am the program manager for CAN-PACT. So essentially the guy on the other end of the emails chasing you for lots of different things. I'll be alongside Hillary actually tomorrow running the PS priority setting partnership and public engagement breakout room, which will be the most influential and critical room tomorrow because it really sets the future agenda for what we want to do, not only just in CAN-PACT, engaging with the public, engaging with clinicians, but also down the line, what we can have long-term impact. So, you know, you can go to the other ones, but really you'll be missing out.
All right, that's enough already. Yeah, all right, thanks.
Part salesman as well.
No, we're good. We're good, not yet. All right, Linda Balneves, and I put Manitoba and Saskatchewan together because you guys got some catching up to do.
Hi, everybody. I'm Linda Balneves. I'm the Associate Dean of Research in the College of Nursing at the University of Manitoba, so I come with a nursing background. I've been involved in psychosocial oncology research for about 30 years. And started off in 2007 doing some of the first studies around cannabis in Canada. And so I've been in that space for a while. And I'm also a member of the Canadian Cancer Trials Group, Executive Committee for Supportive Care. And previously I was involved with the breast disease site for CCTG as well. So. Oh, and the psychosocial. Oh my gosh, yes. It's been a long journey. I'm nearing the end, as everybody knows.
My name is Paul Danick. I'm a physician, palliative care physician, medical oncologist, working in the cannabis space for 20 some odd years. What a long, strange trip it's been. What else can I say? I work as the symptom management for Cancer Care Manitoba. We are small but mighty. Let me tell you that. As a clinician, I've been asked to sit on 3 committees. So I don't know how the hell I'm going to split myself into 3 tomorrow. I think I'll be coming in and out of some of those things. So.
Fair enough.
This type of. Thank you.
I guess I'm the sole representative from the place that brought you psychedelics.
I love it.
I'll represent. My name's Erica Dick. I'm a historian and a comedian on the side. I've been studying the history of psychedelics in clinical trials for about 25 years. So I studied some of the earlier trials that took place in the 1950s and have hundreds of patient data that I can share with you if you like. Lately I've been working more on Indigenous ceremonial uses and how people pay attention to or not policies, drug policies, and how people kind of work along the edges of that, which I'm really excited to work with Dave on the policy committee, which I just learned I'm on.
Go policy. That's awesome. What an amazing group of people we have here. I'm just blown away every time. Okay, we've got Ontario Part A. So if your name's on this slide, come on down.
I guess we're over here, hey?
Yes, so.
Okay, so we have 2 slides that we have to go through?
Yeah, this is part A.
Yeah, and similarly, I did not write notes about everybody, so you're all introducing yourselves. So I'm Harriet Richardson. I'm an epidemiologist and a professor at Queen's University in the Department of Public Health Sciences, and also a senior investigator at the Canadian Cancer Trials Group, where I work with Michael McKenzie and Margot Burnell and Hilary Horlock on the Supportive Care Committee, and get the opportunity to work with amazing people like Linda Carlson and even Linda Balneves, who we sit on the executive. Listen, that's right, Linda C and Linda B, exactly. And it's great to be here. Amazing. I can't believe we're here. It's fantastic. Ron.
Thank you. Hi, everybody. What a wonderful group. You're bang on. I'm Ron Shore. I'm an assistant professor in the Department of Psychiatry at Queen's. I'm a scientist at our Center for Psychedelics Health and Research at Providence Care in Kingston, and I'm a co-PI of CAN-PACT.
Hi, everyone. I'm Wei Chu, another Queen's and CCTG folk. So I'm a biostatistician, and at CCTG, I do a lot of early phase IND trials and supportive care, quality of life. And I did my grad training in Alberta, so happy to be back.
Awesome.
Hi, I'm Policy Dave. I think I've been introduced a couple of times. I've worked about 30 years, starting at the BC Ministry of Health, and then a number of places in Ottawa, including Health Canada, CIHR, CIHI, other places in policy jobs. Also active in knowledge translation work over the years. Came to Queen's in 2021 to help to kind of bring people together, including a number of the folks here, Harriet, Ron, Claudio, I guess is a bit of a sort of catalytic function in starting to kick off some of the work there, which has some roots in what we're doing now.
Okay, I'm Craig Goldie. I'm one of the co-leads of our Division of Palliative Care at Queen's, associate professor at Queen's as well, Department of Medicine, and work in our cancer clinic, work in our inpatient units and outpatient units. Fair experience in cannabis trials and the CAF-CARS trial at Pippa Hawley's project, but very interested in this area.
I'm Craig's other work half. We won't, his partner calls me his work wife. So I feel if she is okay with that then. So my name is Danielle Kane. I'm the co-chair of the Division of Palliative Medicine at Queen's and the director of palliative care at our new hospice, as well as Providence Care, our palliative care unit, and the co-chair of the MAID program at KHSC as well.
Hi, everyone. Claudio Suarez. I'm a psychiatrist by training. Work at Queen's. Clinically, I see patients in medical and surgical floors, and I also do psychology and palliative medicine. I'm an offspring of Dave and in the psychedelic world. So we started a advisory program at Queen's that turned out to be a center now. It's a Center for Psychedelic Health and Research. And we're happy to get funded from Ontario Brain Institute and thrilled to be here. So it's 1 year to make it. Nice.
Awesome. It's so good to see everybody like in 3D. Like I had no idea like Craig was so tall for example. Yeah. All right. Thank you guys. Round of applause. All right. Ontario Part B. Come on down. Right. And this is it by no means, hierarchy better than, yeah, exactly.
Pass for the line.
Yeah, there you go.
Order of your names. That's right. Find your order. I got to pass that to you. I can get them. Yeah, I can do it. Yeah, you're nice. Okay.
We're actually lining up. I love it.
Yeah. Oh. Hi, everyone. I'm Julie, first on the list, and then we're in order. I am the Director of Research for the Division of Palliative Care at the University of Ottawa, and then I'm also the Executive Director of the Pan-Canadian Palliative Care Research Collaborative, which is also kind of the other half of the CCS Breakthrough Team Grant. So really glad to be here with that hat on, so we can kind of work together and make sure that we're sharing resources and aligning priorities wherever we can. And I will be working on the James Lind Alliance work, and then largely focusing on the clinical trials steering committee as well. So really happy to be here and meet a lot of people in person for the first time, actually.
Thanks. I'm Deb Adams. I'm the Registrar and CEO at the College of Registered Psychotherapists of Ontario. I'm thrilled to be here. I'm actually feeling way out of my league. But I started my healthcare work at the Princess Margaret Cancer Hospital like 100 years ago. And then I worked at the Tammy Latner Center for Palliative Care for a really long time. So now that I'm with the psychotherapists, this feels like a good capstone. And I'm desperately trying to figure out how to make it possible for the 17,000 and growing number of psychotherapists in Ontario to be able to provide psychedelic-assisted psychotherapy. There's a real, obviously, you know better than anybody, there's a real drive for that. And we have some huge impediments in terms of the government and our colleagues and other professions as well, who are really struggling with the idea that we might get into that. So I'm excited to learn and to be here and grateful to be included.
Awesome. Hi, everyone. My name is Jeremy Richard, PhD, not MD. So I'm a clinical psychologist by training.
Clinical psychologist.
Yeah, licensed in Quebec and Ontario. So it's a bit weird for me to be looped into Ontario because I'm so used to being in Quebec, but I'm now at the University of Ottawa. And so I'm working alongside Dr. Monica Williams in their psychedelics program. And so right now we have a master's program in psychedelics and consciousness science. And we also have an upcoming diploma program for psychedelic-assisted therapies. And so to train psychotherapists, psychologists, MDs, and other folks there. And so I really see my role here perhaps being more on the education side, although I do have experience also in clinical trial research working with psychedelics as well.
Okay. Hello, everyone. I'm Carolina Mandorena. I'm a psychiatrist, but right now I'm doing a PhD at Queen's University. And actually, the project that I've been working on is setting up a pilot study for the treatment of demoralization using psilocybin-assisted psychotherapy in advanced cancer. So when I was invited to CAN-PACT, I was very excited.
So you're coming to clinical trials?
Oh, yes.
Yes. Okay.
And I've been working with Dr. Suarez as well as my supervisor, Dr. Vasquez, on this.
Hi, everybody. I'm Ishrat Hussain. I'm a psychiatrist and a clinical trialist. I serve as department head and program medical director at UHN's mental health program in Toronto. I'm also the program medical director for the partnership between UHN and CAMH. I am running at last count 8 clinical trials of psilocybin therapy in various clinical populations: depression, OCD, chronic pain, bipolar disorders. And I'm here, I think, also representing Dan, Sarah, and Emma, who are colleagues within UHN Mental Health, and Psychosocial Oncology at Princess Margaret falls within our portfolio. And Sarah, Emma, and Dan are running a couple of clinical trials of psychedelic-assisted therapy for cancer, and also a Health Canada special access program to deliver psychedelic therapy for cancer patients clinically as well. So I think I will be in the clinical trials.
Oh yeah, we're gonna pick your brain for sure. Yeah, that's awesome. All right, thanks everybody. Again, what an amazing depth of knowledge and experience we have in this network. All right, Quebec, come on down. Hand it over to you. And if I can just get everybody for the last couple of slides to keep it fairly brief, we need to transition about 5 minutes.
All right, thanks, Linda, and the team for the invitation. Very proud to be here. My name is Michel Dorval. I'm an epidemiologist, professor at the Faculty of Pharmacy at Laval University. For the last 4 years, I've been leading a group studying psilocybin-assisted therapy in palliative care. Thanks.
Hi, everyone. My name is Suling Chang. I'm really happy to be here. I'm an epidemiologist too. I work at the CHU de Québec Université Laval Research Center, and I'm also a scientific coordinator for Michelle's research program on psilocybin-assisted psychotherapy. So I'm really glad to work with all of you.
Diane Graton. I'm a psilocybin user. For cancer. So that's it.
Hi, everyone. I'm Human Farzin. I'm a palliative care physician at the Jewish General Hospital in Montreal, assistant professor at McGill. I've been involved in treatment of patients, starting with the Section 56 exemptions, and then through the SAP for both psilocybin and MDMA, working closely with TheraSil and MAPS, and designing and implementing training programs. And really happy to be here. Thank you.
Awesome. All right. We're going to do New Brunswick and our one non-Canadian participant. There you go. Thanks, Naomi.
Great. Hi, everyone. So we are also small and mighty from the St. John Regional Hospital. We were all brought together by the formidable Dr. Margot Burnell, who is between here and some CMA meetings today. So she is a legacy medical oncologist with the St. John Regional Hospital, but now is the president of the Canadian Medical Association. So she wrote me in. My name's Naomi. I'm a clinical psychologist with the oncology department at the St. John Regional Hospital. And I did my training in my certificate in psychedelic-assisted therapy and research through CIAS, where I got to learn from amazing lecturers, including Tony Box. So I'm very excited to see you here today. And my understanding is that Julia Wildish isn't involved with the program, but we do have the lovely Jessica.
Hi, my name is Jessica Hemmings. I'm a palliative care clinician working at Horizon Health in the St. John Regional Hospital. I am this assistant professor at Dalhousie. I'm our division head for our program and do have some roles with education as well. Yeah, I'm just very honored to be here. I'm so interested in this and need to talk to some clinicians who are already doing this in practice because I'm not working with it psilocybin at the present time, but thank you.
Hi, I'm Shahar from the US.
Oh, there's your map.
My expertise is precision well-being and integrated medicine. I've been head of the Integrative Medicine Center in Tel Aviv for almost 10 years, and we've met in the Society of Integrative Oncology several days, I think maybe 15 years ago. Yeah, something like that. Yeah, my age. And my role now is I work in Stanford in precision health, and my role is to implement wearables in precision medicine in this project.
Hello, everyone. My name is Claude Botha. I am a psychiatrist, so I'm the head of department of psychiatry at St. John, New Brunswick. I'm also assistant professor to Memorial University and Dalhousie. So doing a lot of training there.
We've got all of the Maritimes.
Maritimes, the cool kids. My background is in psychoautonomics, so neurogastroenterology. I was part of the Wingate Institute, University of London, England, where we looked at visceral pain and modulating autonomics to assist in visceral pain. Ran a few trials there. So I'm very excited to be on this side of the pond and to be part of this.
Awesome. All right. Thank you, guys. Okay, so we met the team and it is impressive indeed. I'm just going to very quickly highlight what's going to happen next. You've all got the program, but sometimes, we don't look at that. So right away, we're just going to shift the chairs around and get ready to have a conversation with Diane. Where'd she go? There she is. Describing the psychedelic-assisted therapy experience from the perspective of a person living with cancer. And we're going to do that kind of a conversational Q&A format with Ron. And then we will have a break after that. I think we've got some nibbles and coffee and tea. And then Ron's going to just get us all up to speed on the cultural and historical considerations of psychedelics, all within 45 minutes, apparently. All of them. And then we'll have Tony back as our keynote speaker, talking about lessons from designing and implementing clinical trials of psilocybin therapy for people living with cancer. And he's done some amazing work lately that hasn't yet been published. So we'll be fortunate to hear about that. And that's the end of the public program for today. And then for network members, we're going to have a really fun networking dinner at 6 o'clock over at the banquet bar near where you're staying. And then tomorrow is kind of a closed meeting for network members. And we're going to start with mindfulness. So don't be so tired from the fun the night before that you can't come and do a little yoga and mindfulness. And then we'll start, well, do we have breakfast tomorrow? Yeah, so we'll have breakfast here. So you don't need to eat at the hotel. And then after breakfast, Harriet's going to talk about the CCTG Supportive Care Committee and kind of how we're working with them. Haley's going to give a little summary of her mixed methods exploration of stakeholder perspectives. And then we're going to move into the breakout session. So we'll have a little break then. And the first breakout session is open committee meetings. So here's where you can shop around a little bit. Harriet and I will be summarizing what's happening in clinical trials, have a bit of a discussion. And the same in education, it'll be Ron and Leah. In policy, we'll have Dave. And is Dave just Dave? Dave needs a co-lead. Policy Dave. And then the priority setting, patient engagement, Chris and Hillary are going to present the work we're doing there. And then we have lunch. And then there's another committee meeting session where we're going to have more working groups for people already on the committees, or if you decide you want to join one of the committees, we'll have the same three: clinical trials, education, and policy. Those three committees will have working sessions. And if you don't want to go to that, or you're not on any of the committees, I encourage you to go to the end of life dialogues with Julie and Hannah. So practical skills for navigating death and dying. So that should be really cool too. And then we're going to finish with a bit of a synthesis period where we're going to summarize the work from the breakout sessions, do some integration, of course, invite people up for some reflections and wrap up and kind of talk a little bit about next steps. So that's how it's all going to unfold. I can't skip that slide. Okay, I really want to make sure we recognize the admin team here in Calgary who's been working really hard to pull this all together, everything, for the last year. So we've got our sort of full-time staff, Chris, Chantel, and Adele. I've got other research assistants here today helping Elizabeth and Raif, and then all our trainees and volunteers. So you met Julie, Hannah, Haley, Nisha, and Jamie, and Laura is also here with a big camera following you around. So if I can get everybody to stand up and really thank you so much. Oh, I meant them, but they deserve a standing ovation, yeah. All right, we're going to move right along now. That's great. Standing ovation. That's cool. They deserve a standing ovation. All right, so just a summary, what we're doing here. We're using research, education, and policy, simultaneously across Canada, this wonderful network and project. And I really do believe that we're going to advance the science and implementation of psychedelic-assisted cancer therapy for many years to come with this project. If you haven't watched it yet, CCS made a nice video where I talk about that. This was sort of part of the launch of the grant. And if you haven't visited our website, I'm sure you have because you're all on there. It's beautiful. And we have Adele to thank for the website, for these beautiful slides, for our awesome water bottles, all our branding. That's all Adele's work, and our socials, which aren't on the slide, but they should be. We have socials now running on LinkedIn, for the academics. We've got Instagram for the young folks, Facebook for the old people, right?